Okay, good morning to everybody. Good morning. I'm not sure if to speak to you or to but no, good morning to everybody. And this morning I'll present some of the lessons we learned over a few years, over 3 or 4 years in Bolivia when I served there as campus director from 2007 to 2 years ago. I don't pretend to be a doctor or epidemiologist or even I don't have an MPH in public health. But I will present this session in the framework of community development. And what we managed to do was we had good staff in Bolivia, health staff, former UNICEF workers, and workers from other NGOs. And together we sat and devised this model. There's many other models. And the framework is again community development rather than medicine. Or so if you have any very technical questions, some of them I may be able to answer, but probably not all. So
yeah, I'll go at one time.
I'll go at one time. Okay. So as we started in 2008 in Bolivia, we were given the mandate of improving health in Bolivia, in rural Bolivia. We had a region, I'll talk about the regions after, in the Altiplano, in the highlands of Bolivia, and in the Amazon also. But the challenge that was before us, and I think it's a challenge before many of the workers everywhere in the world, many of our workers, many of other NGOs workers, was this: how can we implement a community-based, culturally appropriate maternal-child health and nutrition strategy that is both cost-effective and also sustainable, and which can be replicated or duplicated in other parts of the world also. That was a challenge before us that we tried to solve as we set about implementing this project or this program. And just to go through some of the points, some of the challenges or sub-challenges before us working in community, and many of you who work in other parts of the world will have the same issues, the same problems. First, very remote rural settings. In the Amazon, we talk about villages who are separated one to another, by rivers, hours, if not days of distance. In Altiplano also, the roads are inaccessible, they're not paved. During the rainy season, it's very hard to reach those communities. The second point is very limited public health services. If there is a health post, it is very stretched. The staff is usually not well trained. There's hardly any doctors, maybe one doctor per municipality. But definitely no health post per community. People have to walk to their health posts. The staff are stretched, they're not trained, they're usually demoralized also because they have to live with their families sometimes in those communities, and they're city people. So very limited public health services that doesn't reach all of the community members. Very limited funds in terms of our programming. We knew that we could count on some funds from SP UK, from SP US, from HQ. We also had some funding from Canada, and then we also got a small grant from CEDA, from the government of Canada, but it was never a large amount of funding, so we had to administer those funds really well. Fourthly, we're dealing with illiterate populations, mothers who are usually not so educated, maybe up to 3rd grade. Usually no women in Bolivia do high school in rural areas. In the urban centers, yes. In the cities, yes. But in the rural communities, women usually do 1 or 2 grades, maybe 3rd. They learn how to read and write, maybe. Usually not. And they just drop out of school very fast because they have a lot of family chores, either with children or at the household, cleaning and cooking and working in the field. Mothers were busy also. How do we engage mothers who have other tasks, cooking, they have to look after families, sick children, and actually, as most of you know, who've been working in the developing world, there's a lot of burden on mothers and on women, usually, much more than males sometimes. And how do we engage those women in the program? And then the last challenge, or the last point, is that animistic worldview that underlies much of the behavior and the practices. And to us Westerners who come down there, even to some of the Bolivian city people who go down to those rural communities in the Amazon or in the highlands, some of the belief systems, some of the practices, just to us it doesn't seem logical. Some examples, in Bolivia, if you have twins, it is a curse. In rural Bolivia, some of the indigenous groups, it is a curse to have twins because only animals have more than one offspring. So it's actually quite embarrassing to have twins. So what is practiced there, and it's not known. Slowly one of the twins is left kind of to die. He's not being fed. He's not treated as well as the other one. And then you go in Bolivia and it says actually there's not a lot of twins in rural areas. You can hardly see any twins. There's other practices relating to feeding children. For example, the first breast milk. Mothers don't want to give it because they want to have really tough boys, especially with boys. They want to have tough boys who could be resilient, and especially when they go, they are conscripted. They think that when they're conscripted to the army when they're 18, they need to be strong, and so just very strange ideas and behaviors that are based on their worldview, on their animistic worldview many times, and that underlies the health of people there. Let's just go to the next slide. Just a little bit about Bolivia. If you could look at the map, the two dots is where we established offices. One is La Paz, the capital, and the other one is in Trinidad, in the Department of Beni in the Amazon. Okay. The map down below just shows you some of the darker spots are food insecure or poor sections of Bolivia. And you can see that there's some poverty in the Amazon, especially in this area where we established the office here. But a lot of the poverty is actually in the highlands. Potosí, La Paz, up in the highlands in the Altiplano, and I'll talk about those regions in a second. Okay. Okay, the two regions, Altiplano or highlands, the high plateau, very dry and arid, not a lot of producers for agriculture, but there are some Andean crops that were grown there. Population, our beneficial population was about 13,000 people, 2,500 rural families, and 52 beneficial communities. Some of the aspects of this region, where we work, two municipalities, Cataví and Azacara, they had 98% poverty incidence, and 53% of the people were extremely poor. And again, we're talking about rural farmers, subsistence farmers, living from one day to another. Chronic malnutrition affected 35% of the children there, under 5, and 55, more than half of the people lack access to safe water, or any water really, except rainwater when it's raining. They're rural, they're indigenous Aymara people. That's the Altiplano, the highlands. In the Amazon, we dealt with a complete different geographical, but also demographical set of people. Population was 18,000, 2,870 rural families in 30 beneficiary communities selected by our program. And again, the Amazon is very different. It's the lowland, it's rainy, it's green, and yet we found 89% poverty, 95% extreme poverty, 95% poverty, 89% in one other municipality, the one above here. It was very flood prone. Every rainy season we had floods, and that's actually how Bolivia, the Oxen Bolivia started after a flood in Beni, where a lot of their crops and their food and even their cattle was destroyed through those floods, which came every 3 or 4 years, depending on the El Nino cycle. Again, it's rivers, water. There is water, but the water is contaminated usually. So we found a lot of kids with, again, about 35%, 32% of kids suffer from acute diarrhea. So these are the two regions before us, and this is kind of one after another. I'm sorry about that. Anyway, why focus on nutrition and food security? As we set off to Bolivia, to work in Bolivia, we looked for a framework. And we decided to focus on food security and nutrition. Again, we're dealing with rural communities. What we realized is food is a central indicator of absolute poverty. It is the most basic need of people. And if you focus on nutrition security or food security, that's framework. We thought we could tackle a lot of the problems that underlie child mortality and morbidity in Bolivia. If you know Bolivia, it's probably Bolivia indicators of malnutrition, maternal health, and child mortality are the highest in the Western Hemisphere after Haiti. So it's probably the poorest country with the worst indicators, health indicators after Haiti in the whole of the Western Hemisphere, and definitely in Latin America. And even in Bolivia, within Bolivia, like other countries, Latin America, Latin America is probably one of the most unequal regions in the world, a bit like the U.S. actually, where you could find that because of the higher incomes in the cities, the rural areas and the sort of peri-urban areas are so poor. And some of the sort of richest, you know, to see in Bolivia, for example, 1%, the 1%, a bit like the most wealthy 1% in the country is so wealthy that it actually distorts some of the GDP indicators and some of the economic indicators of the whole country. But we're dealing with rural communities where chronic malnutrition affects 27% of the under 5 children. That's more than a quarter of the children. In the rural communities where we worked, 37% were chronically malnourished or stunted, 40% were underweight, and 3% wasted. Over 1/3 of child deaths are due to undernutrition. So this is actually, around the world, malnutrition is so important because child mortality usually is a result, child mortality affects so many children that is worldwide. More than 1/3 of child deaths could be attributed to malnutrition, undernutrition, and any diseases that to malnutrition, for example, diarrhea and respiratory illnesses that is compounded by the effects of undernutrition. So more than 1/3 of child deaths in the areas where we work were due to undernutrition. Again, another reason why focus on nutrition and food security. 50% of infants in our areas were born with low birth weight. And then also, just more generally, undernutrition causes lack of losses in cognitive and productive capacity. We realize that undernutrition has long-term effects, not just on the children and the households, but also on just national poverty and economy. As people become stunted, as they grow, their productive capacity for a lifetime reduces, and it puts incredible burden on the economies and societies in these countries. And particularly in rural settings, what we found out over these studies is nutrition and food security was probably the most effective programming framework for us to use. And I think this is true for many other rural contexts in Africa and in Central America. We could use food security or nutrition security as a programming framework on which you could build other programs, which we'll see in the way we integrate other programs to this, to our initiative. Again, just some conceptual frameworks which I took from UNICEF and made a few changes just to add the spiritual and worldview aspect. If we have here at the top of the pyramid the child's nutritional status, if you look down below the immediate, it's the child's dietary intake, the food that he eats or she eats, and then related to that, at the same level, the health status of the child. So health, of course, affects the child nutrition directly, but child nutrition status also affects child's health directly, and that is related to the food, of course, that the child eats. Under that, you find the household pillar here, household food security, which is affected again by the resources of food. So food production, if you're a farmer, what do you produce? Did you lose your crops? How much food is available per capita? And also cash, any cash income, purchasing power, usually by the sale of those crops, whether it's quinoa or potatoes. How much money, how much income is made by the household? How much of that goes towards purchasing other types of food? And then also transfers of food in kind or bartering. So the first pillar is the household. The other pillar, very important pillar, is the mother or the care. Sometimes it's a grandmother, sometimes it's an aunt. But the care for the children. Again, the caregiver's control of resources, the physical, mental, and spiritual status of the caregiver or the mother, and then the knowledge of and beliefs. That's the third pillar. And that's also very important, even in terms of gender and gender differences in the household. Sometimes in Indian or indigenous families, what you'll find is the men and his sons, the father and his sons usually eat first, and then the leftovers are given to the mother and the small children. So that actually is a big determinant also for food security within the household. Even when there's enough food in the house, the way it is distributed is not always very logical. And it is based on the worldview, on the view that women are inferior, less important. There's a lot of cultural sort of factors there. And then the last pillar here is the context of the environment. The environment where the family or the child lives. And very important aspects here are safe water, sort of drinking water, sanitation facilities, and then environmental safety and shelter. Those three pillars they all lie on sort of the general basic determinants, which is the political economic structure of the country, of the region, which again, indigenous countries in Latin America, indigenous communities in Latin America, until very recently they were very marginalized, very excluded. Now we see a difference with the rise of indigenous governments. In Bolivia, for example, Evo Morales, the first indigenous president in the history of that country, came into power in 2005. There is some differences in power and more attention given to the rural communities, but still they're very marginalized. Sociocultural environment, and then the belief system and worldview that for us Christians, Christian development workers, it's a very important aspect because we realize that many of the behaviors, many of the practices in those communities are based on some belief system, some distorted worldview that affects them. Some of it is very detrimental for the children. Next slide.
Daniel, at the village level, your leadership is still largely male or all male?
At the village level, official leadership is largely male.
Okay.
You get one or two females, but the indigenous Aymaras, and I think that's also true for the Quechuas, the actually very nice thing that we also use is the male leads with his wife together. The chief and his wife lead together. Together. So it's not. So actually, the wife has a very important role also.
Okay.
So how do we integrate food security, and how do we develop the framework? Again, you can see here the health section right here. With some of the results, we were trying to look at chronic malnutrition reduced by targeting children, especially young children under 2 years of age and pregnant women. Then the second point was improved attendance rate, nutrition, academic performance in school age children. That's what we wrote up from this aspect. That was a school feeding program for ages 5 and above. We'll touch more on young children 0 to 5. Then increased access to clean water and sanitation facilities. This is a very important aspect again, because we know that even if there is food, if you constantly have constant diarrhea, any food is absorbed, any nutrients are absorbed by the body are lost through diarrhea. And then also a very important point that we integrated into the health program was improved social health and improve social health through mitigation of substance abuse and domestic violence or gender-based violence. Very important element affecting the health of not only women but also children. You can see here, we won't touch on that, but the goal was to reduce poverty of population in the target areas. We had an agricultural production program and livestock as strategic objective number 1. Again, strategic objective number 2 was to enhance that was our health program here. And then the third one was sort of cross-cutting with local leadership capacity to influence factors that affect food security increase. And here we work with community leadership, municipal disaster response leadership, and then also participation of women in community decision-making processes and powers. This is a general framework of our program. Now we'll just go to the health element, just to go, and then we'll touch on the model itself. So our health program, again, the strategic objective of the health program was human capabilities protected and enhanced. First results that we were seeking was for children under 2, current malnutrition for children under 5 reduced, and again we focused on the youngest children, 0 to 24, although we provided services to all children under 5 years old, and also pregnant and lactating women. Some of these sub-points under that was community-based growth, promotion, and monitoring. That's the model that we'll talk about again in a second. Nutrition education and training for mothers, maternal health and nutrition, improved quality and coverage of community healthcare system. If there was a health post or any activity of the Ministry of Health in the community or in the region, we'll tie that into our program. And then integrated managed illness, the IMCI model. The second result was improved attendance rate of children school age, such as not today. The third one was increased access to clean water and sanitation facilities. Again, potable water systems, if it's the Amazon, what sort of water service facilities or water systems can we build or provide, and then the system and then hygiene also, which is not mentioned here. Improved social health, the fourth point, working with men to reduce gender-based violence, and also training faith-based and community leaders, alcohol abuse and domestic violence. A lot of the violence, like in the States, a lot of the violence was related to substance abuse, especially alcohol. Okay. So with that, again, that's just a picture of the integrated model, and we can see the advantages obviously are those areas, the dark areas are reinforced. This is the household. If the household receives all of those elements, water, sanitation, agriculture, food production, health and nutrition, and leadership, the household is impacted much more than it's just one of those. And then inside, you see your partners, right? The market, where you try to link farmers into the market. The states, any municipal government officials, the Ministry of Health people. The church, very important element for a program. And then traditional community leaders and structures. Some of the advanced notes. First, you're able to tackle undernutrition and food insecurity from different but related angles. Something in the West, we have the idea that health is sort of a separate thing, and if you have a problem with health, you just medicate, right? Now we know that health is related to a lot of factors. Here in the States, it could be bad feeding practices also, but even some other factors which are more social. In Bolivia, we realized that health and nutrition, health was directly affected by the nutrition, by food production, what was available through food production, by safe water, availability of safe water, by gender-based violence, by leadership, by worldview, and that was an important factor for us to integrate the program. Advanced products mutually reinforce each other and enhance the overall impact on household and community. The spiritual dimension also could be incorporated holistically, not in isolation, so we could build on a piggyback, incorporate the church, including also the gospel. That was important also for the integration. And also it saves costs on logistics. When you have projects that are concentrating, agriculture, health, leadership in one or two geographic areas in our case, and the Amazon, it saves on logistical costs because you're focusing on the program and your staff and your transport into those areas. So this is the actual model. What we came up with is this model called family support groups. And we'll talk a little bit about the model. We'll start there. And again, this approach to this model builds on several successful maternal-child health models and best practices, including the Bolivian and also Brazilian Ministry of Health Zero Community Undernutrition program or initiative that started about 5-6 years ago. So Zero Community Undernutrition, Desnutrición Comunitaria Cero in Spanish. It also is based on various methodologies of Brockton from WHO and UNICEF. And also it draws along on the care group model from World Relief, the care group model, and also some of the birth with doctor concept from China. I'll talk about each of these abilities in a second, but I don't know if you have any questions until now, and we'll go towards the model. Just if you have any questions until now, or do you want to continue? And
just one comment. When you said that you included the men, in the program, I think that's excellent, because that's something that I have looked at, and Mary Lou and I have talked at some length about, is that when we go out and address many in the world, and we go and we deal, and there's a very big push, as you know, on right now for maternal-child health. But a lot of the well-being of the family boils right down to the man and his responsibility. They occupy a socially very high, if they get into alcohol and drug abuse or errant behaviors, the family suffers from that. So I think one of the largest areas we can have an impact on is dealing with bringing solidity as a cultural, part for the men. So I think that's excellent that you put that in there.
And to detect all those social issues, it's a bit like in the States, what addiction does to a family and to the health of the sort of youngest. Mental illness, with other issues that are always determinants in the health of even the youngest children in the household. So gender-based violence in places like Bolivia, indigenous communities where machismo, or Latin in general, machismo is the cultural value almost, machismo being. And even in Haiti, we found out that gender-based violence is so rife that if you tackle some of those social determinants, even without doing anything in health, you could already improve the health of children.
Yeah, exactly.
Yeah. So this is the model that we call family support groups, or in Spanish it is Grupos de Apoyo Familiares, if those of you know Spanish. The main concept is based on the creation of the hub, or a community, in which mother can meet twice a month to learn new health, nutrition, and child rearing practices, and discuss themes that directly or indirectly affect maternal child. In the business world, this concept is known as a business incubator. It's a center of idea. It's a safe space, either in a school or if a church. Many times we use a church, therefore we could integrate the church into the program. You see the church here in the center of the model. But if not a school or a health post, if there was a health post, we could integrate the health post or the Ministry of Health Services into that. So it's providing the women in the community, the mothers and sort of pregnant mothers, also pregnant mothers, with a safe space where they could not only monitor the nutrition status of the children, the health of the children, and get the immunizations from the Ministry of Health and all that, but they could also discuss twice a month first, we'll do all the child health and monitoring of them on growth charts. But then the second meeting would be discussing any themes that are relevant to them. So it could be dengue, could be diarrhea, could be sexual disease, and we would bring an expert or somebody who would train them. And sometimes we would train the mother themselves to present those themes and to facilitate the discussion. Also, they would meet to devise different from local food. So we have some recipe books here that they themselves came up with. We just happened to produce that and then to print. I'll pass these around Amazon and Altiplano. And they would just come, and it was kind of a social and fun activity. They would cook together, learn about the different, the importance of different nutrients in different food groups. They would discuss any important theme. Sometimes we could actually bring some gospel themes also to the community, and we would integrate some lessons from the Bible. They would discuss gender-based violence themes, dengue in the Amazon or malaria in the Amazon, different things that would interest them and that were relevant to the health of the children and of the family.
So you guys created all of these recipe books and stuff like that?
With the mothers, yes, with the mothers. Based on local foods. Always the emphasis was based on local foods, what's available in the community, either through the production of their husbands or even just available on the local.
So will that change depending on what area?
Yes, the Amazon has much more fruit and yucca, things like that, banana, plantain, mangoes, much more rich than the Amazon. The Amazon is more quinoa, cañawa, potatoes, llama meat, which is actually very nutritious, cuy or guinea pig meat, things like that. So at the center of this community-based model, it is a community-based model, very organic, local, based on volunteer mothers. At the center of this, there's 5 mother leaders, and these 5 mother leaders are chosen by the community based on different aspects, usually responsibility, based, how their own household or family looks, if they had constant bouts of diseases or if the house is untidy, usually the mothers won't chose. They're usually mothers who the community counts to lead. So I'll just go through.
So Daniel, was it always 5, no matter the size of the community?
It was sometimes 4.
Okay.
Sometimes it was 4. And as I explained, the main 3 mother leaders,
right.
The weighing mother leader, weighing meaning Maternal-Child, anthropometric mother leader, the weighing and measuring, and then the IMCI mother leader.
Okay.
So these 3 were the basis.
The basis, okay.
And then, so the secondary was the wash or hygiene mother leader, and then the family council, which is domestic violence.
Okay.
But you need at least 3. If you can get 4 with the hygiene, it's great. If you can get the family counselor, that's sort of the most complicated aspect, maybe. So let's go through some of the responsibilities. The nutrition mother leader, she was trained to identify local foods that can be used to prepare nutritious porridges, blends, and recreative and traditional recipes from local foods like pre-Incan blends and recipes. She was trained also in nutrition counseling and the promotion of dietary supplements, including vitamin A, iodine, and tablets also. This mother leader also promoted immediate and exclusive breastfeeding for the first 6 months of the child's life, and also proper infant and young children feeding practice for children over 6 months of age. She also received training in cultivating family vegetable gardens within that also, and any small animals like chicken rearing, guinea pigs, or cuy, and other appropriate and low-cost technologies to improve home consumption. Anything to do with nutrition. She was intensively trained in that. The child growth or weighing mother leader, which is right here, Amanda Salora, the folder. She was trained in the use of basic anthropometric, the board, the measuring board, and the salsa scale to weigh and measure young children in the community on a monthly basis when they met once a month, and track the growth on Ministry of Health growth monitoring charts. Children that faltered received home visits, not just with her, but the mother was met, and then it is how many kids were really sick, and who of those children they had to visit. So here's sort of one of the charts that I brought here. I asked Anna from Bolivia to send me this, and you can see the actual charts and the sort of where they measure the kids. Produced by us with, of course, Bolivian Health Ministry form. And what the mothers would do is they would basically measure and weigh the kids, and they put a red dot, a green dot if the child is actually on the curve or better than the curve. That's for girls, that's for boys. And if the child showed any growth of faltering, they would put a red dot under his name. Oh. They would put a red dot under his name, and they would go and visit. Usually if a child gets diarrhea or respiratory illness or some other bronchitis or something, the child will immediately, a young child on the side will immediately drop in weight and in food intake. But if the child shows 2 months of two red dots, basically 1 month, this here is June, for example, June 2011, and then you have here July 2011. So if you get a child who has 2 red dots, this child has 3 red dots, that's some sort of serious problem. What's happening in the family? So the mother will go there with at least one other mother, and will try to investigate what's going on. Is the child sick with chronic diarrhea? Is the mother maybe neglecting? And just investigate the case. Okay, the third mother leader is the maternal-child health mother leader. She was trained to promote infant immunization coverage with the Ministry of Health and practices that positively influence maternal-child health and nutrition before, during, and after the birth of the child. So that's the IMCI, all of you I'm sure know methodology. That was used to train this mother in core intervention to prevent major child illnesses, diarrhea, respiratory illnesses, measles, and malnutrition. Malaria also more in the Amazon, but malaria is not a problem in Altiplano. Even in Beni, it's not a serious problem, but we include malaria in the Amazon. And it also encouraged timely seeking of medical treatment. There's a form here that was used by here if you want to see the form. Any sort of danger signs in the child for sicknesses. And feel free to look at these after also. Let's go to the fourth mother leader, which is the WASH one, or hygiene. She was trained by FP WASH technical staff. Again, that's why it was nice that the program was integrated. We had water sanitation technicians and staff to train her how to repair and maintain biosam filters and VIP latrines also that we used or work with wells. The hygiene promoter also is also trained in hygiene education, proper hand washing practices to prevent diarrhea, and helps mothers, that's very important, helps mothers to establish a designated hygiene corner or station in the house for hand washing in their home. So that mother made sure that in every home there was some kind of a station. Those poor houses, there's no running water, but at least some sort of area where it was a hygiene area with a clean towel and a bucket of clean water, which is designated as a hygiene corner in the house. The last mother was the last mother leader in the group was family counselor. And that was really interesting. Again, she worked with our social work. We have a social worker and also community leaders to identify and support mothers suffering from domestic violence. So either the mothers or maybe the father was beating his kids. We had some cases of even rape within the family or incest. So we work with them to prevent child and mother maltreatment. This includes educating local men regarding laws on gender equity. So again, she was trained with some of the laws. And also lobbying municipal governments to set social protection and domestic violence as a priority in their annual operating plan. And actually that seems very complicated about what that program achieved in the Altiplano at least is that one municipal government actually designated funds to hire a social defender, they called it, which is basically a domestic violence monitor, because the problem was so high in that community, in that municipality. So somebody in the municipal government just that any claims, any sort of serious problems would be deferred to that person, and he would get the police involved. We tried to get also International Justice Mission involved in bringing some of those cases of rape, especially of minors, to the court, but in the end it didn't work out. But this was really great because what we did here is we trained mothers from the churches, and they were able to really go work with the mothers in the community, and if there were serious problems, they were able to advocate the case, bring their case to the municipality or the police.
In general, Daniel, when you started gender equity and things like that, did the men in the village, were they tolerant or accepting of these programs, or was there a lot of resistance? Or
so we had our own social also do sessions separately with women and women. They had their family support unit meet every week, only women usually, and discuss those themes and their rights, and gently also biblical explain to them that men and women are created in God's image, women are not inferior, basing it on the Bible. But separately, we also had our social worker training the men, and sometimes also just leaders or just pastors or a mix of all of them together. And just in really fun and interactive ways, just working with them, looking at different types of violence, even just verbal abuse and emotional abuse, but then also sexual abuse, explaining what it is, what the sentence is, what the law says about, you know, rape, about beating your wife, about this sort of things. Some session, you see the mother registering on a sheet of paper, and here's a salsa scale, and it's probably measuring board somewhere, and the mother's here waiting for their turn. This in practice how it worked out. Okay, this is just every group, every support group had those 5 mothers, usually 4 mothers, for example, in a community of 40 families. So they divided and had specific responsibilities for 10 or 12 families within that community also. Here, what is not included is the counselor. It's a community from the Bolivia in the Amazon. So when they met, once a month was do child monitoring and just register the child growth on the charts, and also I'll explain soon, get the Ministry of Health involved. And the second meeting was to discuss different themes. So that first meeting is very important. In every once a month, usually either at a church or at a school or at the health post. If there was a health post, we really wanted to do it in the health post to get the Ministry of Health involved. What they would do is they divided into 4 stations. The first station was to measure the child. You see a child being measured in altiplano, simple salsa scale. The second station was registration, so it's weighing but also measuring using the board. The second was registration, as you can see here, registering the child, all the data in a book. The third was nutrition orientation and counseling. So the nutrition mother leader would use these charts or these sort of things, depending on the age of the child, to explain what he needs to eat, how many times a day, and she would have all this here behind. Usually mother leaders knew how to read and write, not always, but usually knew how to read and write more, so they were more educated than the others. People look at this. So this 6 to 8 month old babies. This year's for 9 to 11 months old. To 1 to 2 years, as you already told it, how many spoons or meals a day. So that was the nutrition counseling. And then the last spot, we always invited the Ministry of Health to send a paramedic or a nurse and to give any shots to the children if they were missing. So on the chart, on the blue and red chart, I think will be also the shots that are missing. Over there? Yeah. So we gave an opportunity to the Ministry of Health to get involved to try and tie them into the program, not to work in isolation. And they usually came with an ambulance or sometimes to send somebody on a motorcycle. They didn't send somebody all the time, but we always left the spot and we made sure that they know that they were invited and knew when the session was taking place. And really we helped them because we brought all the mothers to one spot in a community where they could just come, drive in, and every mother went through this. Every child, they went through this to have a short view also. Here you could see actually one method that they used here. Again, those are mothers who are not educated, usually don't know how to read and write, they're more visual oriented. So those charts here, to show them in the visual way, we used a flag with red and green, and showing just how many kids in the community were green, were growing fine, their weight and their height according to their age, and then how many children were actually on the red with the growth faltering. And the mothers were discuss what's happening, how come this month we had 5 kids in the red, and usually in winter we have more kids in the red, so we try to investigate and to discuss why. And then we would chart here also the different months, just to make it more visual to them. Again, we didn't use a lot of materials that are books like that. If there are any books, it was more for our own workers or for the mother leaders that could read and write. One thing I didn't discuss is first aid. All those mother leaders also were trained in first aid. So again, just to go through, and here's some more photos of sessions. We have 82 family support groups in 82 communities. It went up and down. Sometimes we were targeting 70 communities, but the maximum we had was 82 communities. They met once a month with mothers to weigh, measure, and immunize the under 5 kids. And then the second monthly meeting was to discuss a theme, a health and nutrition theme, maybe a new recipe put together. The emphasis again was on fun and learning. So some of the meetings, the second meeting, were more social meetings, birthdays or celebrate Independence Day. But we created a space for them, a safe space for them, so they knew that you could come here. It's almost like a mother's club on health and nutrition. After the initial training for the mother leaders, they had two sort of refreshers, 2 to 3 day workshops, extra knowledge, and sometimes some others drop, others come in just to train the mother leaders. We trained about a total of 284 mother leaders, and again, after the session, the mother leaders also have the responsibility to visit the homes of farm. Looking at, if you remember, my first point or the challenge of the whole exercise was how to develop or implement a community-based, culturally appropriate maternal-child health and nutrition strategy that is both cost-effective and sustainable, and which can be replicated. So the cost also was a big issue for us because we didn't have large USAID grants and millions of dollars. We actually spent in the Amazon and in the Altiplano about an average was $225,000 a year over those 3 years, even taking a little bit. So that was for 70 communities, 70 to 80 communities. Average cost per beneficiary per year was $113 for direct, and the indirect, which was 31,000 people, was $7. So it's not the cheapest, but it's also not very expensive. We had about 2,000 direct kids and mothers participating. Here's some of the recipes, the Amazon recipes of meeting, measuring boards. It's all an expensive program. Another nice thing about the integration, and again, this model is a model that you could build upon. You could integrate even other, and not just build upon, but use it as incentives. For the big problem for those of you who work in community development, the big problem is how do we get the mothers or the beneficiaries engaged? How do you get them to come, to participate, to attend the sessions? Even twice a month, it's hard to get those people engaged sometimes. So what we did is we had incentives like latrines, chickens, banana ovens, and all of those incentives, and again, of course, parties and food and that they could sell on. All of those incentives are actually beneficial for the health and nutrition of the children. So, for example, 200 families in Altiplano, families selected with under 5 kids, received 10 chickens each just for protein to produce their own eggs consumption. So that was 200 families there. 200 families with vegetable guidance and gave them seeds. 120 families with dug wells, sort of wells. So that was, again, very good to reduce levels of diarrhea, which is another big killer. After malnutrition, diarrhea is another big killer in most of the developing world. About the third. About more than 1,000 BSF or biofilm filters were given in the Amazon in terms of water. Participation in those groups. If you didn't, priority was always given to mothers who participate in those family support groups. And then also to reduce, probably the hardest thing to reduce is respiratory illnesses in children. So what we did there was just provide banana oven, which is fuel efficient, but also take the smoke out of the building. And because mothers usually cook inside, and the smoke is really one of the factors affecting the health of the children, and so exasperating the respiratory illnesses is smoke from cooking. So a simple solution is to improve their cooking, bring a chimney out. You sell it by telling them they'll use less wood or fuel, but that seems to improve their health. The chimney takes a small cost. Some of the advantages, also some disadvantages, but some of the advantages, it's a single integrated strategy that builds on very successful maternal-child methodologies. Care group is one of them. The care group, the care group is cascading, and sort of one mother trains another, and it's a pyramid model. It's more Western thinking, it's sort of almost mathematical. You train your 12, you train your 24. So we found that creating a habit is much more organic. And there is high levels of community participation via the peer group, sort of club concept. Organic community-based and culture, it's a safe social space for women to meet, so the husbands actually just meeting. Sometimes you'll find in developing communities that the husbands actually don't allow the women by the health practitioner, because the health practitioner is usually a male. There's cultural taboos by spending, especially indigenous women, also in Africa, to be seen by this kind of doesn't speak to culture.
Yeah, we're finding, Daniel, with the Village Samaritan program in Honduras, we thought that because most of our providers are young women, and we have one young man, but that they would be the opposite, that the men would not go to the young woman for care. But we're not finding that to be the case. They are going. And the young man the reticence of women coming to see him because his mother accompanies him.
Yeah.
And so it's, so they've been able to overcome it. But yeah, that is a big inhibiting factor in these cultures.
Again, incorporate the local church in the system, and also incorporate the Ministry of Health Services. Very to incorporate them if they're willing, especially the church. Sometimes the church, we don't want people in our church. It's cost effective because we're using volunteer mothers. Basically, we're not, in disaster or other programs. You just send Western doctors. We try expensive. Integration with other sectors, wash, gender-based violence, food production, and very important, use those as incentives. Let's go to some of the results we've been seeing over the last few years, and then I'll end. So exclusive breastfeeding, if you see the baseline within 2000, we use the baseline first year and then there. 2008, 10, and 12, you see some growth in exclusive breastfeeding for children with AIDS. Not sure what happened here, maybe. Maybe carrying those.
What percent is that, Daniel?
40. We started at 42%.
You peaked out. At 90%, you're at the top.
Yeah.
You're not going to get any higher.
In the Amazon, it was much easier to. I was a town woman, and I'm going next year. Breastfeeding foods for 69 months old, and the second half is time initiation of breastfeeding, which is 1 hour after birth. But again, why was the cultural taboo? Let him be strong and resilient and not feel anything. So you can see here in the Altiplano and the Amazon, so here's a big jump from baseline. From also initiation of breastfeeding within 1 hour after birth. And this is some of the indicating more, but the presentation won't put everything in. Chronic malnutrition, again, for the governor of Bolivia, chronic malnutrition was a big issue. Underweight was not 40% underweight or something, maybe a bit less, but it wasn't a big issue. The big issue in Latin America, some regions, especially Central America, is stunting, which is measured heights for age. So you can see here a big reduction from 2008 to 2010, from 35% stunting, I think 35% of children under 5 were stunted, reduced to 28 after 2 years, and then to 23. And the Amazon, before we started at 17, those statistics are probably not so significant, but still you see a trend from 17 to 14 where we were.
When you have, like on that chart, when you have large difference. It's great. It's easier to make significant change. When you get down to where everybody's doing pretty good, then the major change gets to be very difficult.
And again, malnutrition, we believe that some of those water projects and food production projects affected, it wasn't just the hygiene and the nutrition sessions. There was a lot of the external factors that also affected, and the integration of the programs that helped the whole family develop. Acute diarrhea in under 5s. Again, that was hard because that depended on a more expensive program. I think we did 100 and something wells, like this, 100 wells. We did a few village water systems in Altiplano. But that was actually the before and after. That's where they used to take water before and after. The BSF was used in the Amazon. There's 5,000 water filters. So the impact was not great, but from 31% to 27%. Again, this is measuring all the community as a whole. 30,000 people as a whole doing a survey. Not just so that's where you see the impact is not.
The curve is going in the right direction, Daniel.
The what?
The curve is headed the right direction.
That's good.
Acute respiratory illness is again very hard to. Here actually we found out we didn't need some cocina malena now and fuel efficient with get smoke out. So it's probably the caregivers themselves and just monitoring and the referrals to the health services that help here reduce from, we had really high 55% to 50% and then to 47%.
So those are remarkable. I mean, they would impact on diminishing respiratory illnesses. And they love it installing. I've been involved with that, and they love it.
So using local mud and down.
Yeah.
Which is recommended and
they work really well.
it's design.
Plus the fact it reduces the amount of time spent gathering wood.
Yeah, it is very efficient.
Yeah.
Yeah, so it really cuts back on deforestation and erosion, and so those are very beneficial in a number of ways.
Promoting those stones, WFP, or not exactly those, but fuel-efficient ones to decrease gender-based violence, like women and young girls who get wood and charcoal, if they have to get less, then they're in danger for less time.
Good.
Yeah, and everybody wanted the one thing and using less fuel because less work. We did 200 because I'm from we have fun with 200 now. Okay, that's the sensible length, third shot of immunization with the local. We didn't immunize ourselves, though we had doctors in our teams, and increase, especially in the Amazon, from 68% to 8% of coverage, which was very good. Very good. Just getting the and then 2 visits, prenatal visits, doctor visits, some success. Less in the Amazon probably because of the logistical and I've seen many mothers even die trying to get to the health services.
Daniel, the thing I'll keep going back to, this is the epidemiology. When you're that close to perfect, and 90% is getting near perfect, when you're that close to perfect, to close those gaps is extremely difficult. I mean, what you're trying to overcome there now are things that, are going to take a long time. As we go towards the Millennial Development Goals, and we keep dropping the U5 death rate around the world, keeps sure it gets to 0. The harder it is to make a difference anymore because the many different factors that contribute to that very small percent. Where you reduce diarrheal disease, well, you've made a huge impact. Okay, when you do that with antibiotics or with ORS and zinc, and you've done that. Okay, now then the rest of it, we get down into all sorts of things like food allergies, that could be a huge impact because we can't even get it below 7% in the United States, that's with all we got. So the closer you get to that line, the harder the change becomes. Okay.
Still attendant delivery. 40% in Altiplano. Again, it's quite low, 40%. Usually the kids are, the mothers give birth at home. So we have another new idea about building sort of delivery centers in the community. That's complicated. We'll see.
In Honduras, the rule is there. The government says you will deliver in hospital.
Yeah.
And so with the Village Samaritan program, what we've done is we have that village, the nurse manager, and we have her centrally located. And what she has done of her house, cleaned it up and dedicated it. And so, 5 days before the women come up on their due date, they're coming down now and staying with her until they deliver.
Yeah.
And then to get into those services. So building something like a birthing center,
and training
somebody, I think will have a big impact.
Okay, improved drinking water. Again, that's via pump filters and wells or community systems. Improved sanitation facilities. In Altiplano, we did little sanitation. We had one village where the whole village got actually a toilet. That's in the Amazon, but that's in Altiplano. A flush toilet, actually. But we did other families with simple latrines, but we didn't have a lot of funding for sanitation here in Altiplano, which is, and in the Amazon, every family who got by some fields also received a simple vehicle latrine. Hand washing methods, and there's a lot of material here about hand washing and hygiene when others in the community. Domestic violence, very interesting again. As you say, that affects the health of children, the family, and the well-being, general well-being of children and the family. You can see here the mother's meeting in session in Altiplano to discuss domestic violence, and here integrating the gospel. Altiplano, again, initially, that was women reporting domestic violence at home, so from 70%, that's very high, to 10% in the Amazon a little low. And just to finish, I think that's the last slide, just to finish the kid that we, actually when we did the baseline, we visited his home. That's the first kid that I remember. His name was Joaquin. And he was almost 5, but he had the weight of a sort of 3-year-old. Very malnourished, very stunted. I just wanted to, when I went back last year, I said, hey, that was the first child I went there, and I wanted to see what happened to him. And I went there, and I actually saw him in the church with the Bible, and his Bible, stunted, but looking quite healthy. So I was kind of happy just to bring it in all the numbers and statistics to reality. That's his family. Actually, his mother, he had a father, but the father left, disappeared. No one knows who he was. The mother, I later heard that she went to Argentina to work as a maid, and his grandparents were looking after him. They took a photo during the baseline, and it was really nice to see him. He was attending church with his grandparents. He was healthy. So, just to finish some of the lessons learned that I think will be good for wherever we work in Samaritans first, that we have sustainable, cost-effective programs. I think we have to start shifting from things in infrastructure to people and capabilities. That's really important. Disaster relief, development. I think this is really important. If we stay in the community more than a year, we can't just keep handouts all the time and focus on infrastructure. There's so many empty structures and hospitals and clinics and that just are not used. So we have to shift a little more into people and capabilities. Focus on young children to get the highest impact. Under 5, but even under 2s, babies, and pregnant and lactating mothers. So in any health program, we focus on those most vulnerable, I think they have the highest impact. Prioritize preventive rather than curative intervention whenever possible. I think we have impact, especially child nutrition, diarrhea. diarrheas and resting clearances. Pro-household behaviors related to nutrition, child feeding, that'll have an incredible impact on the health of the child. Sustainability is the system and social capital, the church, schools, traditional system, indigenous systems, and to tie those into to tie the Ministry of Health into the system. Executives, the mothers continue to meet even after we leave. How do we get this? And then to use things action, war, gender-based violence, ministry, and other sectors as a direct effect of the general health of the family, and to use those as incentives, not just to piggyback on the program, but to use those as incentives. So the mothers just kind of, I want to go because I'll get to buy some chickens, or which actually is going to improve their health also. And I think that's it. If you have any questions, or if you want to see those materials.
Daniel, in the villages where you, just from a general perspective, from arriving in the village, were you able to see differences in the village and the way the village took care of itself because you started to pay attention to the people in the village?
Yeah, so we've been in the whole community now for the time of 5 years. Now we're transitioning out, but we've seen an incredible, not so much in terms of infrastructure, but just leadership, again, health.
Yeah, people caring for each other, maybe,
Yeah, the church much more engaged. We not only built churches, did infrastructure, but we've also trained pastors and got them engaged in the community. So we did see a tremendous change.
Yeah, one of the things under the Million Toolbox thing is, because you were there, but one of the things that was pushed is the change that shoebox makes, in a person. But I think the thing that we look at is, okay, we're changing persons, we're impacting a whole community. But by doing that and helping the community learn to your mothers to help themselves, you've now changed the whole culture. And it will, over time, the village itself begins to take care of itself. And then having this, spiritual center that be the church is excellent. So,
and many times the mothers think they're disempowered, basically. They don't realize they can have an impact on the children's health. They just think, well, if you see, hopefully he'll get better or not. But
and you have a question there.
I've been to Thailand, where the mystic belief is so deep. How do you get the people to adapt new thinking and live such as that? And this is probably that's the underlying cause, the root cause of a lot of the practices, and it's the hardest thing to tackle. And it can't be done. It's a process, I think. I'm sure Jody has some lessons from Uganda also, and those of you who worked overseas. But it's just hammering messages, depending what practice it is, what it is, but you can always find biblical values that could go with practices. But also I must say that some of the traditional practices, traditional practices are positive. Soup kitchens or family kitchens, solidarity. There are some practices we actually have to emphasize and replicate. It's not all negative, but it's choosing those detrimental practices and trying to tackle the belief system. If we can get family involved in the local church and try and target some of those lies, some of them, let's take a very simple one, machismo. How do you get women we're not the same, but we're equal in front of God? So it's hard, it's not easy. Another important thing is to target children. I'm not talking here,
it's everywhere.
Yeah. If you start educating some of the older generation, there's those animistic traditions and beliefs are so ingrained, it's very hard to change them, even if they become believers. But the children, schools, and through the churches, you could actually influence children much more. And from a young age, we do that also with the use of latrines. I remember in the last NGO that I worked in Food for the Hungry, we built latrines once for the whole community, and 50% used them. Why are they using those mass latrines? And the mystic belief systems, they saw latrines as, well, first off, dark places with holes in the ground that touch Mother Earth, Mother Earth, how can you dig a hole and then you're strata in the hole in the ground and holy Pachamama? Right. So we didn't understand the anthropology and cultural beliefs behind those. But if you train children, you start with children, I think you'll have a much more impact on the culture in the long term.
Right. Yes, the keys there is time and persistence. Yeah. You stay with it, and I agree.
Repeating the messages.
Starting early. Getting children.
And I think it's important to understand the belief and not just come against it and say, that's wrong, this is right, this is what you need to do. And so the use of stories is one thing that we found really helpful, like just building up a character. This is what happens if they follow this kind of practice, and then look what happens and how healthy and tall and fat their child is if they, for example, and then they can see in pictures and just through telling the story kind of the change in the health of the child that comes to understanding what's behind the belief, not just saying, don't do that, and then making it personal and then seeing the benefit of my child. Why, my child isn't in school, and if you can show them it's because they're sick, and then the reasons that they're sick, you can try and get to the bottom of those practices rather than just saying, you need to send your child to school and you need to vaccinate your child. And to understand what's really happening and why.
All right. Here's another material on violence in the family, domestic violence, gender-based violence that we developed.
Well, Daniel, thank you so much. I do love that holistic approach, and as you said, I think it's an opportunity to utilize that as a hub for a number of various sector responses, and like you said, ultimately you can incorporate the spiritual aspect too, which is great. So